All right, good afternoon, everyone. I'm going to hold the mic so I don't have to lean forward. So, for those of you who don't know me, I'm Brian Dixon. I'm the Interim Director for the Center for Biomedical Informatics here at Regenstrief. And it is my distinct honor, duty, and pleasure to introduce our guest speaker today. So our format, as you can probably tell from the front of the room, is more informal. So I'm going to be interviewing Dr. Carroll, our speaker, rather than us having a didactic presentation with a lot of slides. So feel free to move this direction if you want to, because there's not going to be slides all over the walls. But I want to welcome everyone to today's Regenstrief Education Insights and Learning Series event. And so I'm introducing Dr. Aaron Carroll, who is a Regenstrief Institute investigator. He's an IU Distinguished Professor of Pediatrics. He's the director of the Center for Pediatric and Adolescent Comparative Effectiveness Research at the IU School of Medicine, and he's IU's inaugural Chief Health Officer. Dr. Carroll's research focuses on information technology in pediatrics, the cost-effectiveness analysis in medicine, and health policy. He also is an avid commentator and about health policy, evidence-based medicine, and health for the New York Times, CNN, and other major media outlets. And his healthcare triage video series has been educate and inform millions of readers and viewers. So he has a lot of followers out there. His blog is known as The Incidental Economist. Some of you may have heard of that, even if you had never known that Regenstrief and Dr. Carroll were associated with that. It's one of the most widely read health policy blogs in the world. He's appeared on Good Morning America, the CBS Evening News, ABC News, Now, the Colbert Report, and in the quest to dispel health misinformation. He's written 4 books on medical myths, including Don't Swallow Your Gum, Myths, Half-Truths, and Outright Lies About Your Body and Health, The Bad Food Bible, and then he's also has the rare distinction of having a Twitter post retweeted by President Obama, which I think you must consider like one of the highlights of your career. Anyway, please join me in welcoming Dr. Carroll.
That's very kind. It's great to be here. Thank you so much. And that was way too much, but thank you.
So there is a microphone up here, and I know we've got some folks online, so feel free to come up and ask questions. I've got a number of questions that I will, if no one else wants to ask questions, I've got plenty that I could ask Dr. Carroll, but please at some point feel free to jump in with your own questions. But I wanted to start, Aaron, with one of your primary areas of research and interest, and that is a critique of the American healthcare system, and you've had a number of opinion pieces and videos and everything else where you've kind of tried to nudge the system to action. So you've written extensively, specifically about systemic racism and inequities within the system, and that these inequities were exacerbated, I think, as many of us saw during COVID-19. So I wanted to just start with a question around your kind of immediate action that you're proposing to help mitigate some of the systemic health disparities and move the needle towards better health equality.
I mean, I wish there was an easy answer. I think part of the thing that made me get into science communication and writing is that there's so much that we could argue about where we could agree to disagree. But so often there are actual studies or data or evidence which can answer a question, and we either don't know about it or we ignore it, and we pretend that we could just continue to debate it or argue about it. And inequities is one of them. I'm often baffled that we still spend so much money trying to prove that they exist, and that we even fill grants to prove that they exist. Is there anyone left on Earth who either doesn't believe that inequities like that exist, or would be convinced by just one more study? And so I think a lot of it is trying to push us past the inevitable discussion of, well, does it exist here? Does it exist there? Where else does it exist? And actually try to focus on what we might do to solve things, which is of course much harder. But that a lot of the writing I think that I try to do for the general public is to say, like, these are the things we know. Let's go, perhaps focus on the things that we don't, or where we would want to. But trying to fix the American healthcare system is just a massive undertaking, and it's ironic you asked this now. I'm just editing a piece that I hope they'll print in the next week or so, looking at international healthcare systems, and just that I'm baffled by the fact that all of our arguments are still over how do we provide insurance coverage to a relatively small percentage of the United States that doesn't have it now, as opposed to ever focusing on quality or delivery or what we might do at a larger scale. We just continually argue about whether it should be single payer or status quo, and that those are our only two choices, as if the only healthcare systems that exist in the world are single payer systems or what we've got, when there's so much out there that is different that we could actually learn from.
So I guess just following up on what you were saying, like, what are some of those areas that we should explore? Like, maybe especially you might recommend to trainees or junior faculty as some of those areas where we could actually explore some provide insight or get to interventions to help address some of the challenges beyond single payer system.
Well, it's not even. So actually, first of all, I'll say I'm privileged. So every year I give a lecture or two in the Kelley School of Business's Business and Medicine program, which is a program some of you might have either known about or do, but basically it's an MBA program for physicians. It's one of the biggest in the country, but every year in February, they take a trip to learn about two other countries' healthcare systems. And so in the past, that I have participated in, we've been to Singapore and Malaysia and Switzerland and Amsterdam, and this year was England and France. And so we went in February to do that. And then I was lucky enough to go on another trip sponsored by the Commonwealth Foundation and Academy Health, and we went to learn about New Zealand and Australia and again Singapore, and that was in April. And what struck me is that we focus so often on what makes those countries different, when it's what actually makes them similar that we probably could learn the most from. And I think the biggest thing is that they have a public delivery system, that most people in every single one of those countries I mentioned get their care in a public hospital or from a publicly run delivery system. There's a private offshoot in every single one of them. So it's like even England with the NHS allows people to opt out and go for private care. That happens in all 5 countries again, but it's the minimum. It's a small percentage of people, 10 to 20% at most. Most people are willing to get relatively cheaper yet good quality care at in a public hospital, but perhaps if they want better amenities or more responsive or shorter wait times, they can opt for the private system. And that takes place in government-run NHS, that takes place whether you would look at Switzerland, which is an entirely private insurance system that's tightly regulated and mostly nonprofit, but some for-profit, or Singapore, which is arguably the most private healthcare system in the world, with enormous, basically 2/3 of healthcare spending coming from the private sector for people's pockets. But they all have the public delivery system. We don't have any discussion about that at all. We have a small number of public hospitals in the United States, but they are the exception, not the rule. Most of us, in fact, almost all of us, would get care from private hospitals, be they nonprofit or profit. And I think that's part of the issue, that if we had a bigger public delivery system, that would be something. And of course, I could talk about this for the next hour and a half. But I do think it's what often. We don't ever have those discussions. We don't talk about, maybe we should invest in other big social determinants. Singapore's public housing system is amazing. I think like 80% of people live in what we would consider public housing, and 90% of them own their public housing. It's just a completely different model. But that means that, if they take care of social determinants of health, like housing and food security and things like that, they only spend at the moment like 5 or 6% of GDP on healthcare. And they know they're gonna have to spend more. They'll probably someday get up to say 10%, but nowhere near what we do. But we don't ever have those discussions. We just fight about whether we should have single payer or keep what we got.
And last question on this topic, and then we'll move on. But I'm curious. We have a pretty good public hospital and health delivery system in Indianapolis, and we do a lot of partnering with them. Do you see any opportunities for us to use them as an example, or are there studies that we could be doing with them to help highlight how that kind of almost like reverse translation, how that model could work in the U.S. better than it does in many other places around the country? It's
a great question, and I mean, we should recognize that this is one of the exceptions. That Eskenazi is a public hospital that operates more in that manner. But I would still argue, first of all, phenomenal care. But I still think that Eskenazi, in order to compete as the exception, has to compete on a lot of the same metrics that the private ones do, making sure that it's beautiful, that it's private rooms, that the food is all the stuff we know doesn't matter, but which everyone has come to expect, and leads to competition in ways that don't necessarily impact outcomes. But I do think that if we could figure out ways to do, better studies to show that this is a more efficient way to deliver excellent care, then it could be a model, but it would of course take significant public pressure and a lot of push to make that model larger. Just with the way the United States is right now, it really is the exception, and it's a small minority of hospitals, and it is too easy to get lost in big data.
Good points. All right, so now let's turn to what is arguably your sort of life calling, which is debunking medical and health myths and identifying weak medical research. So just to start out, what kind of got you interested in this area in the first place?
So when I was first starting out as a resident, and then it certainly continued into fellowship, I was amazed at how so many of the people training me, I'm going to try to say this as nice as possible, so many of the people training me spoke with such authority over stuff that was wrong, or questionable. And I was just telling my wife recently, like, I had this habit as a resident where, I'd be told to do something, I'd be like, that doesn't sound right. And then I'd look it up, and I would then like send an email to the entire residency program with my literature search and like what I had found. And I'm sure that angered a lot of people. I don't think I was very popular with the attendings, but I have always been sort of blown away by how much time we focus on the new, like what exciting research is, without ever taking as much time to examine what we already know, and how good is that, and how sure should we be. So much of what we do is just best guess. And sometimes those guesses are right, sometimes those guesses are wrong, but again, we just liable to agree to disagree, as opposed to like, well, is there actually concrete evidence? Even almost all of my funded work has been less about what can we discover that's new, as opposed to how do we take what we already know and bring it so that clinicians can practice better. Most of our big studies were of a clinical decision support system that we built that was just trying to get doctors to practice evidence-based medicine, to try to say like, let's ask these questions, let's get this data, this is what you probably should do. And I guess it's, thinking about novel ways to get that information out there, but I'm much more interested in like, how do we deliver better information to people to use it, than in, let's just find new information that we did not know before. And I think that is a general theme that runs through a lot of my work. It certainly was what brought me to the blog, in the sense that we could bring data and evidence to the healthcare fight when the Affordable Care Act was being debated. That again, There are studies that can answer these questions. What do higher deductibles do? What happens when we make changes in copays? What happens if insurance or access increases? What would we expect to see? Will more people go to the emergency room or fewer people go to the emergency room? And I would see lots of times where it's like, we know the evidence, and so we would write about that. And then even, I think a lot of the columns and certainly a lot of the videos that we do are, okay, maybe there's this new study, but let's place it in context amongst what we already know and how much should it change our minds. And let's talk about the quality of the evidence and what we might take from that. The medical myths sprang from that because it's the same. It's a funny sort of lighthearted way to talk about the same kind of problems. And so it was like Halloween, I want to say 2007 maybe or 6. I was driving home from down here and I heard an advertisement from a hospital system that was not ours, but was saying you could bring your candy in to get it x-rayed to find out if like someone had sabotaged it. And it was like parents were bringing their candy in, the kids' candy, and they were getting x-rays. And I was appalled. I mean, I can't get patients x-rays who need it, but they were going to start x-raying candy. And they were getting a lot of good press around it. And I was like, this has got to be a massive waste of money. There must be some evidence around this. And so like I, of course, went to the literature and I looked it up. And there's a guy named Paul Best who is I think he's an economist, but he was on the East Coast and he had basically made this his life's work, where he, every year on Halloween, would follow up every single police report across the country and see, what had actually been reported, if it was true, and has there ever been an actual documented case of a stranger poisoning or sabotaging anyone else's, candy that resulted in harm. And he found that the vast majority are either hoaxes or they are things that people just assumed were candy, but turned out to be like meningitis or, something else. And that there have been candy poisonings and candy sabotage, but they're all from within the house. There's like, a kid overdoses and the family, got into like Uncle Stash of drugs, overdoses, and then they sprinkled it on the candy to try to make it look like someone else had done it. Or a terrible case in Texas where a father like poisoned their child by poisoning a pixie stick. But the danger was inside the house. And so like, it turns out this is apocryphal. Like it doesn't even happen. And I was like irate and I was like, well, what else could we do? And so at the time I had a fellow who was Rachel Freeman, who a lot of people here will know, who was also brand new to health services research and was looking for, something that she could submit to, the PAS meeting, our Pediatric Academic Society meeting. And I was like, well, why don't you write up this medical myth stuff? And we came up with a list of myths that we could do. We submitted it. It was like mobbed poster at, there. And then I was like, maybe we should write a paper. And so we turned it into a paper. We sent it to the BMJ and it was accepted faster than anything else I've ever published. It was basically like, accept almost with no revisions. They just wanted to cut a myth we had about Thanksgiving because they don't celebrate Thanksgiving in Britain. And then it just took off. And then I was like, well, let's write a book. And so we wrote a book. But the original paper was pitched as medical myths even doctors believe. And it was lighthearted, but it was still focused on these are things like hospital systems are x-raying candy. Doctors are telling people that, turkey makes you sleepy. And they think it, and they know it's the tryptophan. I mean, they even get really complex about it. And it's like, well, the truth is that, turkey doesn't actually have that much tryptophan in it. And ham, pork products and cheese have more, but nobody ever says the ham and cheese sandwich makes you sleepy. And it turns out that if you actually buy tryptophan as a sleep aid, it says take it on an empty stomach, because the worst way to absorb tryptophan would be in a big holiday meal. And so everything's lined up against it to say, like, there's no way that eating turkey is the thing that what makes you sleepy. You just ate an enormous meal. You probably drank a lot of alcohol, and you don't want to do the dishes. That's what makes you sleepy, not things. But it was again, it's the same kind of thing. It's like, there's evidence. There's like, you'd be shocked. Like there, sugar makes kids hyper. There have been so many randomized controlled trials of looking to see if sugar makes kids hyper that the New England Journal of Medicine published a meta-analysis, or at least a systematic review of what those studies said. And they don't. Like, there was even one great study where they took a bunch of kids whose parents said, my child specifically reacts to sugar and gets hyper. And they basically divided the kids up. They gave half of them, Kool-Aid, and they gave the other half sugar-free Kool-Aid. But they lied to the parents and told them all of them got sugar in the Kool-Aid, and they rated their kids' hyperactivity exactly the same, and they all saw it because the whole thing's in parents' heads. They think that their kids are getting hyper because they've had sugar, so they see it, but it doesn't happen. There was no difference in the kids' actual activity. It's just what parents see.
Fascinating. Now, fast forward to 2023. How do we, and going back to the original thread, which was myths that even doctors believe. Now we have physicians, especially medical students, who when they have a question, they're Googling it, or probably today they're asking ChatGPT to answer it for them. So how do we guard against myths and misinformation kind of in the current environment where this is happening on a regular basis?
Well, I think that, it's a great question, and I wish I had an easy answer. I think the problem is that good science communication is slow glacial work that takes enormous amounts of time to build up trust and then to become a trusted source for others. Even when we were talking about trying to get people vaccinated during the pandemic, everybody wanted to figure out the magic tweet or the viral thread or the short TikTok that would somehow just sway everyone to get vaccinated, and that's not going to happen. It's slow, detailed retail work, like one-on-one, trying to gain trust, and you need trusted voices inside the community in order to make that happen. We've always had misinformation, whether it was passed down through families, whether it was in the newspaper, whether it was in books, whether it was on radio, whether it was on the internet, and now whether it's encapsulated in whatever they're programming ChatGPT on these days, it's going to exist, and it is incredibly hard to beat it back. And I don't think there's an easy solution. I could reprint that Thanksgiving piece every single year because the news will once again tell everyone, oh, you're going to get sleepy from the tryptophan. And it's like, and I feel like I've done nothing but talk about that for the last decade. I feel like I've done nothing but, in fact, I swear to God, CNN, just today asked if they could ask me some questions about swallowing gum. And I'm like, we're still doing this? Like, really? Like there's a whole book on it. And how much water we need. This stuff just never goes away. And I think partially that's because human beings like neat stories to explain the world. I take this all the way back to myths. Why do we have winter? Okay, because, Persephone got kidnapped by Hades and ate 6 pomegranate seeds. Well, it's a good story. And then we learned that, that's not how it is, but it took thousands of years to get there. Now we have tight myths or stories about why we get colds, about why we, aren't feeling well, about what would make us healthier, about how the system works, and it's very hard to break those, especially when people that trusted voices are often voicing misinformation. But it's important to keep that work going.
All right. And again, feel free to, if you have questions, to come up to the mic. Oh yeah, go ahead, Nicole.
Yeah. Yeah. So when the pandemic hit, and it was March, and we sent, I say we now as IU, but it's fascinating. Like in the School of Medicine, I never would have said we. But we sent all the kids home on spring break, and then we basically said, like, don't come back. And then the world ground to a halt, and everything shut down. And the university, it wasn't panicked, but they were very concerned, and they basically were like looking around, and they were saying like, we got to figure out how do we weather the pandemic, and how do we open up again, and how do we keep everybody safe? And they had tons and tons of questions, and they didn't know what to do. And to be honest, the only sort of medical person that the university had any contact with was Jay Hess, who was the dean. And so they said, hey, can you put together a committee and let's figure this thing out? And so they started what they called the Restart Committee, and it had, you know, the deans of the schools of public health, and it had you know, some people from environmental safety, and it had, you know, the general counsel. And as they were sort of casting about, I think for slightly lower level people who, you know, would come to the meetings and actually, you know, grind out the work, they asked me to join. I would imagine because I've been writing a lot about the pandemic in the New York Times and other places, and what I thought we should be doing. And a couple other, oh, you were on the committee too. So there you go, Brian Dixon as well. Yes, you know, so now I'm thinking of the long ago. Yeah, so, and never forget, it was a long time ago, but yes, I remember that time when you had the like indoor thing on that. Yeah, anyway, so we would meet regularly, try to figure out like, how do we operate in the pandemic? And then when it became time to institutionalize this, we'd had a lot of debates about asymptomatic testing and what we were going to do. And I was part of a group that was pushing very hard that we needed to build our own mechanism for testing, that the state was not going to do it, and IU Health was not going to do it. And like, if IU was going to do testing, we needed to build it up at a big scale. And so when we finally sort of had that meeting and said, let's do it, then President McRobbie said, well, you do it. And so I was now like in charge of surveillance and mitigation. But as we weathered the pandemic, and then as we came out of it, I think there was a lot of discussion amongst leadership at IU. And when I say IU, I mean, you know, not the School of Medicine, but like IU, that we needed this kind of infrastructure long term, that it couldn't be that if the school had an issue or questions or concerns that touched on health or public health or even wellness, that the only person they could ask was the dean of the School of Medicine and the executive vice president for clinical affairs. He was too busy. They needed, you know, someone medical / public health that could fill in that role. And so they asked if I would do it, and I was actually pretty excited about it, because I think the pandemic changed me a little bit, in the sense that I spent my entire career in research, and this was much more of a service role and much more of a how do we actually how do we translate what we know into practice? And so I got pulled into that. So what do I do today? We're winding down the COVID response, but President Whitten, when she came on board, the first big thing she wanted to do was really address mental health. And so I spend an enormous time. We've got a student mental health initiative going on that, you know, we had to create a strategic plan, get it approved by the board, get it approved by the president. We set up some task forces. We ran those for a few months, convinced the CFO to give us the money, and we've been implementing that for the last year. But we also have a host of other issues that we'd like to address across IU in terms of health, in terms of other policies that we'd like to address. And so that's what our office is concentrating on right now. But specifically, what do I do every day? Like I fulfill these roles, and we have these strategic initiatives, and we, you know, have plans and things that we want to build. But I also serve, you know, the president or President Whitten, in the sense that when something comes across her plate or the university that touches on health or public health, now they have someone to give it to, who, you know, my office, you know, sort of tackles it and handles it.
So thank you. That's really helpful. And I have one quick follow-up question. Yeah. If you could name, so you said mental health, if there are 2 to 4 big health issues that you see addressing in the next 3 to 5 years, what would they be?
I would say that the things that have me concerned at the moment that we're trying to figure out, one is actually access, and this is less for students than it is for faculty and staff. I mean, Bloomington is a desert of health providers. People have to wait sometimes a year or more just to get in to see a primary care clinician. And so we're working hard, and hopefully we'll have announcements soon, you know, to address that. I worry about, I mean, mental health is still a big one. Another thing which might sound small, but has been a big focus for us this year are scooters. You may not know, but we've had 2 students die this year on scooters down in Bloomington. And those things are just a menace. And we had assurances from the companies that had dealt with Bloomington and IU and how it all might work out, and even IUPUI and other areas. And we've been in a lot of negotiation, and that gets politically tricky because Bloomington, the city, was of course all for scooters because they saw this as a way to improve climate change. But it's having a major impact because the students, of course, when do they get on a scooter? It's like 3 a.m. when they've drunk too much and they don't want to drive, and oh look, a scooter, which they've never tried before. They don't have a helmet with them, and now it's pitch black and it's a recipe for disaster. So that's a big issue. I'd like to, we'd like to do some work focusing on nutrition. We're trying to focus big time on just broad vaccine policy because we've seen a lot of pushback because of the COVID vaccine against other vaccines. And so, trying to figure out how we thread that needle is super important. And, we're also trying to address cost of care for students as well. We are one of the few Big Ten schools that it appears doesn't have insurance available for students, but there's lots of thorny things to try to figure out and how we do that. And then I think the other big things that we're looking for is that, as you probably know, the School of Medicine as well as the rest of the university just went through a huge strategic planning process, IU 2030. And two of the pillars are student success and serving the state. Both of those probably have reasonable health components associated with it. And I'm hopeful and eager for our office to get involved in how we implement those writ large to make things better for students, faculty, and staff in all the campuses.
We have a couple of questions from the chat.
Sure.
Yeah.
The first one is, hold on just a second. What do you think would be needed to reorient the U.S. to be a more preventive healthcare system rather than an interventional one? We know that $1 invested in prevention can save 10 to 100 downstream. The U.S. is very money oriented. Why does this argument never seem to stick?
So I will be one of the people that will be very unpopular for actually debating that statistic. And in fact, I wrote a column on this years ago that's still one of my personal favorites, in that when we look at the cost effectiveness of preventive measures that we do, almost none actually are dominant. Almost none save money. It's like vaccinations, and for a period of time, it was baby aspirin for secondary prevention of heart attack. Otherwise, prevention is massively cost effective, massively, but it is not cost savings. Very few things that we can do prevention-wise cost savings. But in writing that article, I wanted us to change the argument in that when I think about healthcare systems, I always think in terms of access, quality, and cost. And the problem is that we want all three of those to get better at the same time, and that almost never happens. Like, I can improve quality, but that is either going to cost money or I'm going to have to limit access in some way in order to have the money to do it. I can make the system universal. You can have anything you want. That's going to cost money, or quality is going to suffer. And I can make the system cheaper, but usually quality or access will suffer in some way. And I think prevention should be argued as a outcomes good. It's about quality. Prevention makes people healthier, makes people happier. It makes better people. It's good. It's an absolute good. I don't need it to save money. I want it because it's a massively great way to improve the health of people. One of the things that blows me away in the United States, we've already given up on the cost thing. We spend $1 gazillion. I don't know why we just don't like. And in fact, in October of 2019, I was on a panel for the APHA meeting. And I was there because it was all about, should we have a cancer moonshot? I don't know, a public health moonshot, or that was the title of it. And I was arguing, I don't understand why public health always succumbs to this. We need to be cost savings as well. Nothing in medicine do we worry about, will this save money when we implement it? We're just like, oh, it might work a little, spend as much as you want. And it might not even work. Still spend as much as you want. We've got with prevention stuff that works. It works and it works well, and it's a massively cost effective. That's why we should do it. But how do we change the system? I would argue that like we should stop framing things and accepting that false framing of that it should save money, and start talking about it, about how much people's lives would improve and how much healthier they'd probably live longer and they'd live happier, and it would be great for everyone, and we should spend lots and lots and lots of money on it, because it would be good.
Another question from the chat. And it just jumped. Sorry about that. As we think about disparities in health outcomes, do we know how patterns of health outcome variations within the U.S. social, ethnic, racial groups compare to patterns of health outcome variations across similar demographic groups in other countries? Example, are in-country health outcomes variations similar, larger, or smaller across groups in other countries?
It's hard to answer that like quickly because so many things differ in other countries, both healthcare systems and other systems which affect social determinants of health, above and beyond sort of like looking at trying to classify them according either to race or even socioeconomic class. But I can say it's very clear that minority populations in almost every country suffer. When we're in New Zealand, they're in a massive restructuring right now to address the fact that the Maori, their native population, has been had significant disparities for a long period of time. And they're a large part of their country. I think it's, 17 to 20%. The indigenous populations of Australia have massive, inequities and health disparities. And I think if you look at any resourced country, marginalized populations absolutely suffer in terms of outcomes. The extent to which they suffer can be mitigated by, less inequities perhaps in the healthcare system, or by better safety net programs, or by other initiatives. And it's you look at what is going on in New Zealand's current healthcare reform, and we'll see if it survives the next election. But they are trying very, very hard to address some of those disparities head on. It's another thing that we could learn from, in that their consciousness and their intention in actively addressing this and creating new structures in the healthcare system specifically to address a lot of those inequities is really impressive.
And I have one more from the chat. You mentioned the access deserts in Bloomington. What are the opportunities for primary care, telemedicine, remote services to address?
Well, I mean, I've always been a fan of telehealth because a lot, and again, I'm all for access, and so I think that there's a lot of ways to improve it. And in fact, with the Student Mental Health Initiative, probably the biggest thing that we've done in the last year was get the money and then actually do the RFP, figure out which company, and get telehealth. Mental health care for all students, 24/7, 365 days a year, unlimited, no insurance, just pure access. We have tried to do that as much as we can with the EAP program for faculty and staff. It is not as well received as we're hoping that timely care will be for students. But I think there's still a lot of primary care that people do want in person, and there just aren't enough providers in Bloomington. But even then, the hospital, it's a nice addition, but there's still just not enough for sort of the population that exists in Bloomington. But again, this isn't just Bloomington. A lot of our regional campuses have the same kind of issues where there's not a lot of infrastructure to take care not enough infrastructure to take care of both primary care and behavioral health and mental health. But there's also not a lot of providers. And if they do exist, that's not where they want to work. And so we wind up with not the sense that there are too few healthcare services, but they are geographically poorly placed, where there are parts of the country and the state and even cities where there's too many and a lot where there's not nearly enough. We could theoretically correct that with telehealth, but it's hard to set up that infrastructure, and it's not as if there are physicians in other parts of the state who are twiddling their thumbs with nothing to do. They could just pick up the slack. We need to find sort of novel ways to increase our ability to deliver healthcare services and put them where they need to be.
Yeah, go ahead, Rachel.
This has been so great. Thank you. I have so many questions I could ask you, but I'll start with just thinking about one topic related to access to care. And you can answer this, I think, and you could probably speak for 2 hours on this topic. But what have you seen, I guess, locally and nationally in terms of quality metrics? How do you incentivize access to care? What has worked nationally? What could we do? Where do we need to go in the future, both nationally and locally?
Yeah, with respect to quality metrics, I mean, so I try very hard because a lot of times when I want to answer a question, I'm like, I've written a column on that. But it's part of the problem with quality metrics is that we often pick what's easy to measure, not what we actually need. Because again, we don't think that doing this stuff should cost money. We won't acknowledge the fact that if you want to improve quality, you often have to spend money. Some things are worth it. Sometimes good things cost money. But when we pick quality metrics, it's what can we cull from administrative data without lifting a finger? And that's how you wind up with like 30-day readmission rates. When everyone says bad metric, it's going to backfire on you. It's going to show that the hospitals that are already less resourced aren't performing as well as the hospitals that are massively resourced. It will solve no problems. Everyone knows this going in, and then still what do? 30-day readmission rates. And then we conduct big randomized controlled trials, and we find out, oh yeah, that wasn't a good idea, and it doesn't work. And we're all amazed. And then in 6 months or a year, someone else will propose, hey, why don't we do like 60-day readmission? It's what's easy to do versus what's right. It's very hard and expensive to measure, I think, what is really quality, and it's probably really hard to define it. So I don't have an easy answer, but I guess the broader answer is again, I wish we would start having a conversation about if we want to do good things, they will likely cost money, and we're going to need to invest in them. And that this idea of finding the magic bullet of what will be, improve access and will make things better and will save us money never works. Information technology, EMRs, this was always the promise. Everyone, oh, it's gonna make things so much better. It's gonna improve quality. And I would argue that again, clinical decisions, the real meat of EMRs is that the clinical decision support can improve quality, and it should cost money to do that. How do EMRs, what was the first thing we did with EMRs though? We learned to bill better. And we didn't learn to bill better. We were providing no good things. We were just now finding ways to recoup more money for it. So we wound up costing the system more without actually doing anything to improve quality. So then later, if we figure out ways to improve quality, now we're costing the system even more. I mean, that's the one thing EMRs have always been great at, forcing us to document better so that we can meet the arbitrary guidelines of whatever organization has decided this is how we should bill. And when we do clinical decision support or we do other things, often it's things that cost money or infrastructure, but they do good. So, let's own that argument and try to push that forward.
Thanks. Yeah, and we've now covered most of the items on my list. But going off of that last point, so whether it be CDS or access or quality, what are, putting on your researcher hat, what are some things that you think Regenstrief could be doing in some of these areas, like studies that we should, collaboratively approach, especially given we're going through strategic planning right now. So it's an opportune time to sort of think about what we should be doing as we move forward.
Well, let's be clear. I think Regenstrief does a lot of this work. I mean, it's like, and I and everyone else here could talk about the many ways that they're doing that work, and that's the stuff I get passionate about. I think where I would hope to nudge us a little bit is the frustration I think we all have is that we write a big grant, we get funded, we recognize that building up the infrastructure to do these interventions that we want to do costs a lot of money, and they work, and then they go, great. Now, how are you going to make that happen without spending another dime in the real world? And then all of a sudden we start pulling away all the things that work because they want to figure out how do we actually just implement it without the massive piles of money that it took to do that. It took massive piles of money to make this work. Like it's not as if like all we do is pay for the measurement. It often takes that, it's infrastructure, and we have to get better about, making these arguments up front. When a drug gets tested on the market, they don't all of a sudden say, great, now let's get everyone this drug and not charge a dime for it. But the interventions that we do, there is that weird expectation, and it's health services research again. I think it's informatics. It's like, how do we keep all of this stuff going, but without making any big changes and without any kind of extra investment? That's why stuff doesn't get out there like it should. Now, once in a while you hear about, and I could look at where companies will, that's what it often takes. It's like a company or like some kind of money engine to keep this stuff going. Maybe we could do a better job of that, of how do we actually, translate this stuff into the real world? How do we actually make it operational? And as researchers, I think very few of us do that. And that's part of the excitement of, I think, why I've enjoyed sort of the transition to chief health officer is it's the doing, but the doing costs money. Like the number of meetings I had to say, here's this whole mental health initiative. It's going to cost millions of dollars. Like if you think I'm going to do this for nothing, well, we'll get nothing. But if you want good things, cost money. And pushing and prodding and needling, we finally got the investment. And my plan is to spend for 3 years, and then at the end of that be like, look at all the good we did. Do you want me to turn it off? Or, we're going to need more money, and we need to find ways to pay for this, because that's actually how stuff happens. It's not all of a sudden it becomes free after the research period or the setting up the infrastructure is over. But we're not good about owning that this is important stuff that we need to pay for just as much as we need to pay for an operation or a drug.
And similar, but related, yeah, right, is how about on the education side? So now you do have this role at the big university level. Yep. What are ways that Regenstrief can help, we do some, as you said, we're already engaged in many ways in doing education and training, but are there specific areas or initiatives or things that Regenstrief could be more involved with to support training, whether it be physicians or others, students on campus?
So this is where you're getting Aaron Carroll's opinion, and I fully recognize that it's just an opinion of one. One of the things that has been very surprising, well, one of the things that's never been surprising to me is, and I'm sure most of you know this, you get too far away from this building and people do not know what we do. I think that the outside perception of what Regenstrief is versus the inside perception of what it is are often very, very different. Lots of people think, oh, that's the place they keep the data, or that's the place where they made the EMR, as opposed to the depth and breadth of research and health services research and patient-centered outcomes research and translational research and name another domain. But basically there's so much that goes on here, I think, that people don't know. The other thing is that I think that we get very insular in the School of Medicine. It has been an unbelievably educational experience for me in the last few years to sort of see what is actually out there that's IU that we don't know about. If I described to anyone on any other campus what Regenstrief does, they'd be like, oh, I get that, but it would be all the social scientists. It'd be the economists. It would be the sociologists. It would be, but here we work with all the clinicians and we work with we see bench scientists. But everywhere else, it's much more, and we don't have those connections with the social scientist often, and we don't sort of build those bridges to a lot of different domains for which there's a real depth of expertise across many campuses, because it doesn't feel medical, or it doesn't feel clinical, or because we've all been so, hard science trained that we don't recognize that there are like real partnerships that could occur across there. And I'd say educationally as well. I think, you could probably attract a fair amount of interest from some of those domains I just mentioned. I mean, I think economists, there's so much that could be done with Regenstrief in that domain. And I think that, a bunch of others as well, but we get siloed in and we get boxed in, and I think there's a lot out there that people don't get.
Well said. Last question is, and then again, we'll check to see if others have questions, but something on a more personal level.
Sure.
So I know you're a big Star Wars fan. Lucasfilm recently announced a new series of films. So what's your level of excitement? Tell me about that.
They could just film them like sitting in a room just talking, and I would watch. But it's yeah, I get excited about everything. But I mean, this is the golden age for like everything that I loved as a kid that made me like an absolute nerd is all of a sudden what's popular. Like and then my parents, like I have an enormous comic book collection. No one cared until like the Marvel movies came around. And it's, I was always into video games, and like now they're just like everywhere. And I big Lego sets and all. Like it's like the golden age of, I don't know why, but everything that I wanted to be into is all of a sudden everywhere. Plus, it's like I know this sounds ridiculous, but it's like the amount of like content to watch, and it's just so. We had 4 channels when I was a kid, and you had to get up and rotate the dial, and half of it was like reruns of something from in black and white, and so I'm excited about all of it, and I probably have every streaming system that there is, and all the stuff that my parents deprived me of as a child is the stuff that I'm all consumed with now.
So how do you find the time to do that and still continue your video logging and blogging and New York Times writing? And
so I am pretty efficient. I work at these things pretty consciously to get better at the skills. Like the reason I started blogging in 2008 or 2009 was largely because I realized my job was being a writer, and I had never been trained. I write grants, I write papers, I write talks, I write emails, that's my job. And all I'd ever been trained to be was like, I'd avoided any class with writing. I just wanted to take tests. And so I was like, the only way I'm gonna get better at something is by practicing. You want to be a great piano player, you got to practice piano. You want to be a great basketball player, you got to practice playing basketball. If I wanted to be a better writer, I had to practice writing. And so I committed that for every day for 2 years, I was going to write 800 words. And I figured at the end of 2 years, if I wrote 800 words a day, eventually I'd be pretty good at writing 800 words. And that was how the blog started. And so I would set aside an hour or two every morning, and I would force myself to write like 800 words a post. Sometimes that was one big post, sometimes it was a couple of posts. And what was I going to write about? Well, healthcare reform was in the news, and I know about healthcare systems, so that's what I did. And over time, I became pretty good at writing 800 words. And we kept going. So, we were going in 2000, all the way through 2013, and then other places would once in a while ask me to write, a column, and we were getting reasonably well known in the blogosphere. But it was practice. It was grinding it out, and I must have written at least 1 million words on the blog at this point. But it was learning to write it. I will never write the great American novel, but like I can write 800 words pretty fast these days. And in fact, when we first started writing for the New York Times, the Upshot, where the department of the paper we wrote for, had a thing where they were going to have a couple journalists, but their big thing was like academics are going to write every day. And so Tuesday was going to be Justin Wolfers writing about economics, and Wednesday was Michael Beschloss on history, and Friday was Brendan Nye on political science. And I cold emailed the editor, and I'm like, do you have anyone to write health policy? And they were like, oh, sure. And I had a big fight with my writing partner, because he was like, they're gonna laugh us out of the room. And I have no shame. So I was like, well, let's just see. And that was it. It was a cold email, and they were like, you guys can have Mondays, you'll split it. And we were irked, because everyone else got to write every week, and we had to split it. But we've been training ourselves to write 800 words a day for years. And it turns out 800 words a week for everyone else was just, they couldn't do it. And they bailed in like 2 months. And we were the only ones left standing. And we were like churning out columns for the next 6, 7 years. You know, about 3 times. I would write about 2 or 3 times a month. But because I got good at writing 800 words. So I try to be intentional about working hard at developing the skills that I think I need to succeed, which makes me, I think, a little bit more efficient at what I do. You know, as well as getting better, I'm really conscious about time management. And I'm also very, you know, my self-care is finding the time to do those things. It's like, that's what I'm a real introvert. I'm a professional extrovert. And so I get, at the end of the day or the week, I'm exhausted. And my wife jokes, I just want to put on my earphones and kill some people online. Or, you know, just, you know, play a video or read the comic books or do, but I'm open about how much time I spend in it, because that's how I recharge. And that's, you know, self-care. It helps that my kids are used to be into the same things. They're sort of heading out now, but it was also a good way to spend time with my family and kids as well. But I think those things are like how I recharge and, you know, come back to do more.
Excellent. All right. Well, any other, we've got there's like 1 or 2 more minutes, unless I'm reading the clock wrong. So is there any other questions for Dr. Carroll?
Aaron, by the way.
Aaron, sorry. Yeah. All right. Well, if not, please join me in thanking Aaron for a fantastic discussion today.
Thank you. It's been great.